So before we even begin, we're going to have Dr. Farah and I speaking this morning, but of course we all know each other as colleagues, so at the end just ask questions. You can always email. That's my email on there, and Dr. Farah has her email, and this is the lecture, but there's an ongoing conversation if you have questions. So I live and work in New York City. I'm a clinical professor of dermatology at Weill Cornell, dermatologist, and I spend most of my week doing hair, surgical and medical. My talk this morning is going to be on the surgical aspects of transplantation. And the way to think about it is, just like as a dermatologist, you see broken blood vessels and then you deliver the laser to treat it, or you have a basal cell and then you cut it out. A transplant is, the vast majority of people with hair loss will never have a transplant. Overwhelmingly, you're going to treat them medically and only medically. But for some people, transplantation is really the correct thing and the only way to get them where they want or need to go. I have no conflicts what I'm speaking about. And as I said, the key thing is, with transplants is that it should look totally natural. That's not a novel thing. I would say that's been the case for the last, frankly, 20 years. Anyone that you see a transplant that you can tell was done, it's almost always an iatrogenic mistake in where they put the hair. And that's because we do follicular units as opposed to plugs. So if one conceptual point is, if a patient asks you, will a transplant look natural, doctor? The answer is yes, it will. It's just a matter of where to put it and where not to put it in people. But what's so important, and this focus is really mostly on male and female pattern hair loss, but this is true of all hair losses. When you think of surgery, you think of a definitive answer, a definitive solution to a problem. A transplant adds hair back, and it's based on the theory of donor dominance, meaning you take the hair from the back of the scalp and move it to the front. It's going to grow long term because the genetic destiny of the hair in the back is not affected by the male and female pattern hair loss. That is true. But it does absolutely zero to prevent the underlying medical reason that led to the transplant in the first place. So unless you have successful medical therapy, you're trading hairs. Right? That doesn't mean the transplant is a net positive, but most of us want maximum long-term hair. So if you're going to do the surgery, remember, continue successful medical therapy. So I emphasize that to every patient who comes in. Clearly, if someone comes in and says, I've been on stable hair loss combination therapy for 5 years and I want my hairline filled back in, let's sit down and talk about it. We'll do it. You're going to be happy. And someone who's like, I'm on no medical therapy, I'm rapidly losing my hair and I want my hair back the way it was when I was 18, that's a long medical discussion before you even get to surgery. So just remember that. These are the main medical. Finasteride, minoxidil, Dr. Farah will be talking about PRP, lasers, but these are things that are definitely heart and soul of medical therapy. I'm going to be focusing on the surgical part. And don't forget combination therapy too. The key thing is compliance. In the consult, what are the key points? In any procedure you're going to do on anyone, there's always key points of what to emphasize, what makes somebody candidate selection. In hair transplantation, how much resource do you have? How many hairs per square centimeter do you have in the occipital scalp where you're going to take it from? Not all of us are the same. Some of us have 80, 90 follicular units per centimeter square, and some of us have 50. That's a tremendous difference about how much you can actually transplant someone. So if someone comes in and says, I want 1,800 grafts in the front, well, you don't have that donor density, or you do have that donor density to do it. So you can't change that. Other key point is, what kind of hair are you transplanting? Coarse, wavy hair will cover in a coarse, wavy way as opposed to fine, thin hair. So my analogy is, if you have a backyard and you have thin reeds between you and your neighbor, you're going to see right through that. If you have thick bushes, it will block the view, the same amount of trees you put back there. Same with transplant. If you take someone with very fine, thin hair, like maybe the person standing at the podium right now, and you transplant them, it's going to transplant in a very fine, thin way. And if you have somebody with a beautiful wave, and I see a couple of people in the audience with this beautiful flowing hair, that's going to, equal numbers of hair is going to look quite different. So you just set that up. Pre-op, it's done in the office. It's a local anesthesia procedure. That actually makes it a nice procedure. For those who are dermatologists, you know that most of what we do is multiple patients a day, 20, 30, 40 patients a day, doing a variety of things. Transplant takes multiple hours by the nature of what we're doing. By trying to remove hair from the back, move it to the front, it takes a team, which again, as a dermatologist, if you don't do it full time, if you do it even 1 day a week, 1/2 day a week, it's a nice change in pace. You have one patient for the morning that you do. You get to know them, you talk to them. So we go through the informed consent, mark off the area you're going to transplant. The anesthesia, I think, is very straightforward in the sense that it's local. These are the key differences. You're trying to keep an area numb, not 15 minutes for your excision, but for 3, 4 hours, 5 hours, 6 hours. So Little Pearls is to add Marcaine. Marcaine is longer acting, local anesthesia, and to go back and reinforce with lidocaine every hour or two before it wears off so they're comfortable. I think a key thing for a good morning for everyone is good ergonomics, meaning comfortable chairs, good room temperature. Encourage the patient to get up and tell you when they want to take a break, go to the bathroom, eat something. I don't care. If someone says, I'm getting hungry, all right, we're taking a 10-minute break. Eat something, have something to drink. I need to check my email. I'm like, no, it happens. You know, I'm like, I run a trading desk. I need to, like, okay, check it, you know, because so people stay calm. Donor harvesting. You'll read about this. There's 2 different methods. Both are equally valid. There's the FUE, which is the direct removal of follicular units from the posterior scalp, and there's elliptical donor harvesting, which is an excision of hair. No different than excising a mole or you're excising a hair from the back. Both are equally good techniques. Why? Because both in the end result in follicular units you can move to the front. One is the direct removal, FUE, and one is where you remove the ellipse and then your staff separates them. So I'll show you here, this is a donor ellipse, and to orient you, this is a patient in the prone position, and we're taking about a 0.8 centimeter wide strip in this case, and how do we get our numbers? By length. So sometimes we take these ellipses 15, 18, 19, 20 centimeters long by 0.8 centimeters wide to get the number. So you can close it under minimal tension. You can close however you want. Running sutures, I like staples because you've got a 20 centimeter long wound. It's quicker to close it, and it takes the tension off the wound. And you can see the hair. This is one of the advantages of an ellipse. The hair is lifted up. Ergo, that hair that's lifted up there, above there, you drop it, it's covered. So if you do a man or woman with an ellipse, they walk around New York the next day. No one sees the stitches in the back the next day. Okay, now you understand why nearly 100% of women are going to go with an ellipse. Because to do FUE, which I'll show you shortly, you need to trim the hair in the back to 1 millimeter. And a lot of men are like, I don't want the stitches, I don't want the linear scar, I'd rather little pinpoint scars. But a lot of men too, they say, I'm not wearing my hair short, I don't care if there's linear scar back there. Again, this is why both are equally valid. Choose it to the candidate. This is the ellipse, and basically we just subdivide under magnification. We keep subdividing down to the follicular unit. You don't need a microscope. Any device that you can see these follicular units well. It might be a microscope. It might be magnification, loops. There's all kinds of wonderful devices you can use. You keep subdividing down to the follicular unit. And this is FUE. And here you can see FUE. It's such a nice concept. You just take it directly from the back. What's the appealing about it? There's not a single stitch in the procedure. I can sit in the consult and say, if you do an FUE procedure, you're not going to have anything bigger than 1 millimeter today in your whole scalp. That's appealing to a lot of people. You can use robotics. You can use non-robotic devices. They both work. The majority of people doing transplants these days are doing non-robotic devices. They're quite good and a fraction of the cost of the robot. The robot is quite expensive, amazing technology, but I'm here to say you can do it either way, robotically or non-robotically. And this is just to show how, as this happens to be the robot, we use non-robotic devices too, how we're removing the follicular units while the robot makes harvest to be efficient. Again, we're trying to keep this procedure in a reasonable time. So it's removing the things and remove the follicular units right away. And this is us removing them. We put them in a Petri dish as a holding solution. You do not want desiccation. In 5 minutes, the graft is dead if it's not moist at all times. So this cartoon explains everything. This woman up top will never trim her hair to 1 millimeter, or not never, maybe, because the hair loss bothers people so much, but there's no need. The scar will never be seen. Guy comes in and says, I like to wear my hair short, do FUE. So both. I think if you had to pick one and you're a novice, I think FUE is easier to learn than to take a strip and subdivide. If you said to me, Mark, I have to only do one in my office, I think the learning curve with FUE is probably quicker than to learn how to subdivide a strip. But I think in terms of for our patients, they're both equally valid. And then making the recipient sites, again, most people, we have successful medical therapy. Most people want the maximum donor density. So you don't want to destroy their existing hair. Don't randomly go through there with a 20-gauge needle and knock out hundreds of hairs. Use magnification, wet the hair, and you can see here, I'm going in between existing hairs to thicken with little incisions. We place either using microvascular forceps or implanters. Both can work well. Sometimes we inject PRP. As well, the post-op instructions, patients resume normal activities right away. I think the biggest impact is not to do heavy exercise for a week while the donor area heals, either technique. Emollients in the donor area for a week, and there is scabbing and crusting for about 6 to 10 days. And the results take about a year and a half to fully grow in. They begin to grow 3 to 6 months, so this is not Botox or fillers. This is something other than once it grows long term. And this is, frankly, a before and after. This could have been a medical patient. This could be a PRP, laser, finasteride, oral minoxidil patient. Happens to be 1,000 grafts to thicken in a stable. This is a total home run. This is stable medical loss, a couple of surgeries, 2,500 grafts. Look at that coarse wavy hair. This is not a typical result. This is a way above average result. Women, stable hairlines, just to make the point, the exact same technique, equally good results. The main thing in women is to thicken, thinning hairlines in female pattern hair loss. Again, female pattern hair loss is a stable, thinning hairline. So we're thickening it, and you can make quite a nice difference. Scarring alopecias, key point is do it in one stable. We don't know when it's stable in a scarring alopecia. Wait at least a year or two off medical therapy before you do a transplant. And tell patients if the inflammation returns, you've got to go back to your dermatologist and manage that. But again, it can be quite satisfying to restore hair lost through a scarring alopecia in patients, and patients appreciate it immensely. So think about it as an option for our scarring alopecia patients as well. Here's a woman we just helped restore a hairline with 750 grafts. How do you integrate it into your practice? Enthusiasm. Look around your office. Someone who seems interested in it, like that's cool, is the person you want to train. Because remember, it's a team procedure, which again makes it exciting. Don't forget to train the person in your office with you when you learn how to do it, if you're just beginning to do it. And if someone's interested, it's a technically very achievable procedure to do. If someone's not interested, they're your amazing Mohs tech or amazing cosmetic filler Botox assistant, but they kind of roll their eyes at hair. Don't force them to do hair. Have the person who's interested doing it. So in summary, surgery, consistently natural results, a fantastic complement to medical therapy, to restoring hairlines. Medical therapy often can't do that. Transplantation can do that. FUE and donor lips are both equally valid and effective donor harvesting techniques. And between the two, you can make huge long-term impacts for patients. Thank you for your attention. So our next speaker comes to us from the University of Minnesota, where she runs the cosmetic unit and has a particular interest in hair, and she's a global leader in hair in our research and a great colleague to work, and I look forward to listening to her. And she's our social media director for the AAD? For the AAD as well, American Academy of Dermatology. So it's a pleasure to have Dr. Rhonda Farah speak to us next.